So we have the court martial now, and thank you very much, Tityal sir.
And maybe we'll come back to earth who can tell. I guess there is no one to blame. We're leaving ground. Will things ever be the same again? It's the final countdown. The final countdown. We're heading for Venus, and still we stand tall. 'Cause maybe they've seen us and welcome us all, yeah. With so many light years to go and things to be.
Fun, that makes it interesting, that makes it captivating, and that makes it enjoyable. So science, ophthalmology should be fun, should be enjoyable, and should be a lot of learning. That's the concept of court martial in ophthalmology. And thanks to the team of the court martial in ophthalmology who have gradually groomed court martial in ophthalmology to the 103rd session today. So a big round of applause for the 103rd session of court martial in ophthalmology today. So over the years from 2010, it's 13 long years, and you can see that all these faces are there who were there in court martial in a boss, Grover ke boss, mere aankh se aankh mila ke rakho. So this is what and you can see Professor Lahane in 2010. अरे boss, क्या हो गया? साउंड का क्या हुआ? आवाज बंद हो गई आपकी? देखो इधर देखो, यहाँ पर somebody come and help please. अभी देखो. So, Dr. KPS Malik, sir, you are here. I just talked to Dr. KPS Malik, who was there as well. And this is in 2010. Professor Lahane, our very favorite judge, but not a very favorite of the public prosecutor because he never hangs anybody. Sir, in this last season of my chairman as scientific committee, please promise to hang at least one. So 103 sessions now. And we welcome the supreme judges. Our judges are Dr. D. Ramamurthy and Professor T.P. Lahane. And as is customary, the courtroom shall rise to welcome the judges. Everybody on your And now who you must welcome. It is none other than the Good Defense Council. So let me give you a short intro about our Good Defense Council. For 103 sessions of court martial in ophthalmology, whether the surgeon has murdered the eye, has glutenized the eye, has ransacked the eye, has daggered the eye, but she's there to save them all. The pretty angel, Dr. Chitra Ramamurthy. Give her a big hand, please. And this is what I am. I'm going to be the honest public prosecutor. I might be rude. You can smile, Dr. Shaiban, but I think there's a thin new news which can even fit into you. So I will be honest, and it's science. So if someone has done a fault, the penalty is there, and this courtroom of law shall not waver in its penalty either. So we have our honorable jury members now, and let me welcome Dr. Sri Ganesh, Dr. Mahipal Sisdev, Dr. Rohit Om Prakash is here, Dr. Mohan Rajan is going to join us very shortly. Dr. Namrata Sharma, Dr. Harbans Lal, and Dr. Lalit Rama are going to join in. So let us start off with our court martial, and may we have your permission, honorable judges? Thank you very much. So we have our first presenter, the Dr. Sachin Mahuli. So the Dr. Sachin Mahuli Sachin, Srinivas has a presentation elsewhere, so can he? Right. Ek minute, boss. So we have just reversed roles now. So Srinivas, let's go. So hand on your heart, Srinivas, and in Kannada, take your oath.
ನಾನು ಏನೇ ಹೇಳಿದರೂ ಸತ್ಯವನ್ನೇ ಹೇಳುತ್ತೇನೆ, ಸತ್ಯವನ್ನು ಬಿಟ್ಟು ಬೇರೆ ಏನು ಹೇಳುವುದಿಲ್ಲ.
Dr. Sri Ganesh, is that okay? Right. Okay. Kind of. Okay. So, Dr. Srinivas, shall we start the trial?
Yes, sir.
Okay. Here we are.
So this was the case of the optic disc pit. You saw that there's a huge subretinal fluid bound there in the previous OCT. So here there are various techniques I'm going to describe under how we do fill this optic disc pit maculopathy. When it involves the macula, we call it ODPM. So here the first step is to do a thorough vitrectomy and induce the PVD. And using the IVTA, I'm trying to induce a PVD, and now you can see the PVD is well induced. So the next thing is to put the BBG so that I can stain the ILM. And here the intention is to cover the optic disc pit. So here what I did was, since it was a very large optic disc pit, you can see it's almost covering almost the size of the disc. So here I took the ILM, which is at the peripapillary area, but fovea sparing. Because if you try to do it under the fovea, sometimes there are chances that there's macular hole. But the pit was so big, so I had to take a little bit of ILM from the temporal side of the fovea as well. Not just the peripapillary area, but also the temporal. Now you can see that island where I have taken that pit. Now the crucial point here is to do a very careful fluid air exchange, because sometimes these flaps might get dislodged and might come into the extrusion needle. So here, now you can see the post-op results. The patient had a good visual recovery. This is the next second case where again you can see there is a schisis in the inner layers of the retina along with a large subretinal fluid. So here, as it was not that big as compared to the previous case, so what I did here was to induce a hinge-like effect. So here I am trying to use the ILM and leave the edge at the peripapillary area, that is at the disc margin. So the meticulously we have to peel it, otherwise if it gets shredded, then again stuffing it becomes difficult. So you need the ILM in a single sheet. So here now you can see I have just the hinge like effect, I have left it, and then I stuff it inside in the optic disc pit. The IOCT is also confirming whether the flaps are inside the disc pit or no. So that's the another advantage you have if you have the intraoperative OCT also. It tries to help you out, and there is a theory which is believed that there is some negative suction inside the optic disc pit which keeps the flaps remain intact. So here I am just trying to stuff it. You can see there is no dislodgement of the flaps at all. So this is the pre-op and the post-op, and the patient did have a good visual recovery. And this is my last case, which was operated very recently. And you can see a very tall subretinal fluid, tall edema. It's basically optic disc pit maculopathy, not the general edema. Here again, I'm doing a vitrectomy, and inducing a PVD is very, very important, because it's thought that the vitreous traction is also one of the possibility for the pit maculopathy being happening. So here I use an amniotic membrane to stuff it inside the disc pit. So I take a piece of the amniotic membrane, and then I go inside. And here now, the challenge here is, under the fluid, the membrane might keep slipping, but once you get a good grip of it, definitely you can do that. And now you can see here, I'm just trying to stuff it inside that disc pit. And once this is done, very careful fluid air exchange, again, as I said earlier, is very, very important, because we don't want that amniotic membrane which is stuffed inside to come out. So this is the at presentation. This is 1 week post-operatively, and this is 1 month post-operatively, and the further follow-ups of this patient is still awaited, and the patient is really happy with the visual recovery. Thank you very much for the presentation. Thank you.
May I begin the trial? And we have Dr. Sachin Mauli as a vitreoretina surgeon. Anybody else as a vitreoretina surgeon here? You are the vitreoretina surgeon. Okay. Yes, sir, come in. Come and sit in the front bench of the class. Yes, she is. So may we begin the trial, sir? So it was an excellent surgery.
There was 3-line vision improvement in the first case, 2-line vision improvement in the second case, and 4-line vision improvement in the last case.
What is your follow-up?
Follow-up is, these 2 cases are nearly around 2.5 years now. The last case which I showed, sir, it is just 1.5
May we
months.
have the photographs of the follow-up of the 2.5 years? Serial by serial. He was the operating surgeon, madam. He has to show the documentation.
4 minutes, how much to show? You have
Documentation, flash of a second, 3 seconds. Where are they? Why should we believe you?
Sir,
We believe in good documentation. You have an army of people, subordinates to help you, and yet you do not document. Is that so? Yes or no?
We didn't know that court martial.
Why did you do a ILM peeling, whereas only a PVD induction is quite sufficient for resolution in most of these cases? Number one. And especially with subfoveal SRF, as per many studies. So what was the rationale behind the ILM peeling? And again, the plugging as well.
Shall I answer it now, sir?
Yes.
Okay.
Yes.
So,
Okay. So I'll go to the third question.
Yeah.
In your case 3, the case 3 was important, was incomplete, but because there was no follow-up. In fact, none of the ones have a follow-up there, and the visual outcome. And why are you using an IOCT in these cases? Are you not confident
Your
of
Honor.
the peeling
Objection.
itself? And IOCT in such cases is just about what is a femtocataract for a cataract surgeon.
Objection, Your Honor.
okay.
I
So
would
let
like
me,
to
Go
intervene.
ahead.
Yeah. I mean, now the public prosecutor, when he doesn't have any baseless allegations, he now tries to say that the modern technology also has to be excluded. Shame on you, public prosecutor. This is a science. You only
May
want
we
to-
ask him for the
No, I
evidence?
think all the three
One minute. You will
approaches
have to
of-
answer.
Yes.
1 minute. He has 4 objections.
Yes.
And instead of saying he is not good,
Okay.
we
The
are
right
in the
answers.
science. Listen,
Yes.
that is different. We are in the science.
Yes.
You answer 2, 3, and 4.
No, he had said just a PVD induction is enough. There is a belief that
Dr. Srinivas, would you like to
Okay.
answer?
can
Sir.
do.
just the PVD induction has proved in the meta-analytic study that it is not substantial and it is not enough.
Do you agree to that, Dr. Sachin Mauli?
Yes.
And some have even used the scleral patch grafts also,
Yes.
not just this. So why would they try to do that? And reputed hospitals in India have also used the scleral patch graft. So that means there is a rationale for to plug something is because think that as the age goes on, because these are the cases who present at the age of 40 years or 50 years where the liquefaction has already happened. So once this liquefaction happens, then the most popular theory is because of the vitreous traction and the vitreous fluid going in through the pit and causing the ODP maculopathy, optic disc pit maculopathy. So that's the reason why we did ILM peeling. And definitely the amniotic membranes we have just started few months back. So to compare the good results between the ILM stuffing and the amniotic membrane stuffing, I need little more time to compare between the two techniques. But in the stuffing cases, definitely we have achieved a good response than earlier. What we used to do was only vitrectomy, PVD induction, and just doing a laser. So that caused more scotomas. And plugging it helped the patients a lot. And
is the stuffing more important, or is the ILM peeling more important in recovery of vision?
sir, the fovea sparing ILM peeling has to be done. Is first thing is to relieve a little bit of traction. There is a traction, and that the ILM also causes a traction. So there are two good things in this. One is doing the ILM peeling at the peripapillary area. It reduces the traction. Second thing, the same can be used like a hinge-like effect and stuff it inside the optic disc pit. So it acts both like a plugging also and reduces the traction also.
The third case you showed where this amniotic membrane graft was, do you think the size should have been reduced significantly?
Yes,
I mean,
sir.
it was
I agree.
too much of excess.
Yeah, we could
tissue
have
was
taken
there.
a little more smaller in size, definitely, because it's so small that sometimes it slips off. So what I thought was, if I put it inside, we need actually a diamond duster or any such of instruments to push it inside. So since I did not have that at that point of time, I had to use the forceps very delicately to try to stuff it inside. So when I use the smaller ones, I have seen sometimes it comes out while doing a fluid air exchange. So little bigger membrane probably might stuff inside, but I definitely agree with your point, sir. The smaller size could have always could also be
most of
better.
us are not VR surgeons, so just for our information, what happens to this material which is stuffed inside? Does it integrate with the disc tissue? It's always made out as a separate.
Amniotic membrane doesn't get disintegrated, sir. It always stays there. It causes a scar formation. Even people have tried, Stano Rizzo has tried using amniotic membranes even for the macular holes. And he has very specifically told in the last New York ASRS that it causes a scar formation. Anatomical closure of the macular hole happens with this amniotic membrane as it gets disintegrated. But it never tries to improve the functional outcome. But here we did not use it for the macular hole because we wanted a mechanical barrier. So that's the reason why we took the amniotic membrane instead of using the ILM. Because the only other danger of using the ILM is if you try to peel it over the fovea, it even causes the macular hole also. So that's the reason we tried to use some adjuvants, because even Dr. Naresh Babu Kannan from Arvind, he has tried even the scleral patch grafts and he has showed very good results with this optic disc pit maculopathy.
I think we'll go ahead with this jury
Any
opinion.
jury?
Is there any comparative study with and without ILM peeling, just stuffing?
Yes, sir.
And what does the study say? I mean, is there
You
an
mean
RCT?
without ILM peeling
See,
and
one
with
is,
ILM?
One is just stuffing without ILM peeling. The other is stuffing with ILM peeling. Is there any study which shows
There are a
that
lot
there's
of
difference?
studies. Lot of
Actually,
studies
there are
in the
lots of
literature.
studies, and no, the meta-analysis that you alluded to, does it actually show that both together yields better results?
Yeah. It's better to use the ILM stuffing, or you can even place the ILM, but sometimes what happens if you place the ILM over the disc, and when we do the fluid air exchange, there is all possibility that it can reverse back. So that's the reason why we try to stuff it inside the pig. Of course, we don't have any large case series in this because the cases are not that common. So once we have large case series, then we can have a good comparison of doing ILM, without ILM, amniotic or scleral patch grafts.
Okay. I think opinion of the jury, guilty, not guilty.
No. Okay. I think everybody he has done good work. See, if there is a hole, we are always heard, seal the hole. Now what you are sealing is a different thing, but what you are using is different. But whatever he has done is a perfect. And I think the public prosecutor is always against the good doctors. So he should not be. So my request in the further cases, that he should also appreciate if they are done the good work. Thank you very much.
Oh, he did that.
And he is not guilty. So,
हमारी एंट्रियां दिल में बजी घंटियां रे टंग हमारी एंट्रियां रे दिल में बजी घंटियां रे टंग दिल की सब कमेंट्रियां रे प्यार की गारंटियां रे टंग
So now we have a very, very glamorous surgeon, Dr. Abhijit Desai from Mumbai.
ना मरम्मत हो ना कोई वारंटियां रे टंग हमारी एंट्रियां रे दिल में बजी घंटियां रे टंग
So, Abhijit, before you say one word,
Okay.
you have to take your oath in Marathi.
What kind of oath?
What kind of oath? In the court of law, you ask what kind of oath?
मी खरे बोले.
मी जे काही बोलतो ते खरं बोलतोय आणि मी जे काही केलं ते पेशंटच्या भल्यासाठी केलं.
No way.
आपला फक्त शपथ घ्यायचे.
ही मी अशी शपथ घेतो.
मी जे बोलेल ते खरे बोलेल.
मी जे बोलेल ते खरं आहे,
खरे बोलेल.
खरं बोलतोय,
खरे नाही, खरे बोल.
खरं बोलतोय.
Okay. So, are you starting? Shall I play from here or you start?
No, I'll play from here.
You okay? Carry on. So change over, please.
So I don't know whether to say thank you for the court martial.
You have to say all your thanks at the end.
Okay. So this is not playing there.
I think public prosecutor has made something.
Abhijit, if it is the same, I'll play it from here. It's the video that you sent to us.
Same one.
Yeah, then let me play it from here itself. You can start. इसको play कराओ भाई.
So this is a case of a young boy with a TheraBand injury, and on examination, patient had at least a 180 degrees subluxation out there with a vitreous prolapse. Came with a white cataract and hand movements. We couldn't see the retina. So we proceeded with doing the vitrectomy first after staining it with triamcinolone. At all times, we have to maintain the chamber so that more vitreous doesn't prolapse. You should use a very high cut rate for these kind of cases. So this is a dispersive viscoelastic that I used during the case. This is a 2.2 millimeter incision, and I make my ports for the capsule hooks beforehand. As you see, it's difficult to do a rhexis in these kind of cases, so we've stained it with trypan blue and we use the forceps so that we have a better control on the rhexis. We try to aim the rhexis at around 4.5 to 5 millimeters. And once the rhexis is complete, we use capsular hooks to anchor that particular area where the subluxation is. Being a young patient, the phaco was uneventful. It was a soft cataract, so I didn't find any problem doing the phacoemulsification. So once the irrigation aspiration is done for the cortical matter, this is the time you can decide what is to be done. I was trying to remove the plaques from the posterior capsule, which was not possible. They were pretty sticky and I didn't want a PCR out there before I could manage the subluxation here. So after putting a dispersive viscoelastic again, I am putting in the CTR out here. I like to put it through the side port because it gives me better control. And using a Sinskey hook, you can always put it in the bag. There are different ways of doing it. This is just one of them. You remove off the capsular hooks at this stage, and I make a periotomy out there. I'm using a Gore-Tex suture out here, which is put into a 25 gauge needle, and I pull it out through the main wound and put in a segment, put it through the hole in the segment. Now this is a lasso technique which I decided to use. Now it's important to be very careful that the needle doesn't go through the capsule. So you use a second instrument to dip the capsule down there. Now I have made a lasso out there, which I will pull out through the main wound. So it is very important for this loop to be, the free end of the suture to be long, because you're going to hold it there and then pull the loop out again. So once the loop is pulled out, we have the entire suture going through the segment. And then you can put in the segment inside the chamber and position it where you want it to be. See, here you have to be very careful because the segment is a pretty long one. So there are 3 dialing holes on the segment. Using that, you maneuver it into the bag and you see to it that the loop which is there stays above the rhexis. And then you pull the suture and tighten the suture as per the centration of the capsule. Once it is in position, we are going to tie the knots out there. The way to tie the Gore-Tex is to pull both the free things together at equal tension, because otherwise you don't get a tight knot on the Gore-Tex. And the first knot has to be a bit loose so that you can titrate the tightness of the entire suture. Sometimes it's also good to have a small vicryl suture through these knots so that it doesn't slip at all. And then you put an IOL in the bag. And remove off the dispersive viscoelastics. Stain again with triamcinolone, check for any residual vitreous tags, and close the case. And you can just cover the suture, the conjunctiva, by taking a stitch, or you can use a cautery, or you can glue it up. Thank you.
Thank you very much, Dr. Abhijit. Before we begin the trial, I'd like to invite Dr. Reena Sethi to join the jury. Madam, please. And there's a purpose for you to join the jury, ma'am. So,
Thank you.
wait. So it was a fantastic technique. It's the technique to go to. The Gore-Tex suture is the suture to be used because time has proved that The other sutures that we have been using for a very long time, the Prolene suture, degrades over time, and possible mishaps can happen with the IOL falling, secondary IOL, or a suture being falling into the vitreous. So Gore-Tex is definitely there, yes. But your surgery, I have a few things about the surgical techniques that you have used. So why did you not use a Hoffman's pocket in this case? And that's you will have time to answer. In this case, was it that it was overlooked by you? You did not think it was necessary? You thought every other... Madam, the mouthpiece can be a little farther away.
Why should it be away?
Just a minute, ma'am. I have not finished. I have not finished, ma'am. So, because in an intact globe, making a pocket is much simpler, much easier. You could have done a very elegant Hoffman's pocket. That bulk of suture, Gore-Tex is a bulky suture, it could have slipped in and given more cover than just the simple conjunctiva over the Gore-Tex suture. But did you not even think about a scleral pocket? A scleral pocket would have done in a less elegant way, taken care of the large suture that is kind of on just lined by the conjunctiva. And it's only the conjunctiva that you had. So this is my great contention here. The second thing is your rhexis was splendid. Let's clap for him. This was a traumatic cataract and with a very bulging bag where the cortical matter, the intralenticular pressure was much high. You did a fantastic rhexis. But don't let this message percolate to all us smaller mortals, because that's not the right thing. You should have started off with a small rhexis, sucked out the fluid matter, decreased the intralenticular pressure, then gone
Objection,
ahead.
Your Honor.
Meaning that the
long.
risk of the capsular extension of the rhexis would have been mitigated, would have been minimized. Even in the best of hands, that's important. So you got away in this case, but you as an experienced surgeon might not get away in your next case. So let's be as much safe than be sorry. So this is what I find you guilty of. You as an experienced surgeon, the message that has gone in is not correct. The technique that you did for the Gore-Tex, not correct.
Objection, Your Honor.
Would you like to defend your case with a few sentences?
No, he has a defense counsel. So you,
Okay. I did not do a Hoffman pocket or a let's not talk about the scleral pocket, because in a Hoffman pocket, the tightness of the Gore-Tex can't be titrated that well as opposed to an exposed.
I would disagree. It can be. Yes, go ahead.
The second thing is, yes, I did not think of a scleral pocket, and I don't think the Gore-Tex suture has any problem with only the conjunctiva overlying. It's been proven over and over again that the cut ends do not jut out, and in fact, they become a part of the tissue over a period of time. And that's why it's a safe technique to even leave an exposed suture out there with just the conjunctival cover. It just disappears over a period of the next few weeks.
as far as the surgery, everything is fine. I mean, there's very little to complain.
I said fantastic, madam. Why are you saying
We
fine?
are not going.
I said fine.
Your turn to
please keep
talk
quiet,
is over. You heard that? So you keep quiet. So I'm just paying you back in your same coin. So now he has the capability of creating a nice big rhexis. You don't hang him for that. Okay.
What should I hang him for?
He finds it silly to make a small rhexis when he knows in his hand he will get a nice big rhexis. You saw the ease with which he operated, the way he did the vitrectomy. Everything tells that he's a absolutely capable surgeon. So a very capable surgeon can take some risks. A mediocre surgeon has to be careful. Chapter closed. As far as the thick Gore-Tex suture is concerned, he's quite, you like to anyway find fault when there is no fault. He is clearly saying that a conjunctiva closure is enough. So you can ask him for documentation maybe.
Jury, Mahipal?
I think public prosecutor has some valid points.
Incidentally.
I would always like to bury the suture, because an exposed suture under the conjunctiva, a big knot will cause foreign body sensation, conjunctival erosion over a period of time. So that is something, either a Hoffman pocket or a scleral pocket, definitely.
Shall we hang him, sir?
No.
And of course, I always prefer to do a double rhexis, because you can't predict the intralenticular pressure in an intumescent cataract.
Yeah.
When you try to make a large rhexis, if it runs off, then you can't put your CTR and your CTS. So always decompress by doing. So those are valid points I would give him. But
Incidentally.
again, an excellent procedure. He has used a standard technique.
Oh, what?
Standard technique. Here, it's here.
Yeah.
So he has used a standard technique, and he has used Gore-Tex.
Yeah.
And of course, he did the vitrectomy with staining with red.
Yeah.
So all that we give him points. But of course, if the pocket was there and if the suture was buried, it would have been better,
More
because
ideal.
long term, we'll have to look at conjunctival erosion.
The jury's comments are absolutely the scientific comments. I mean, the fun is between the public prosecutor and...
So, for a change, Partha, you have made out some valid points. One more thing, I don't know, basically at a later, he could have done a pars plana route for the vitrectomy rather than that. So you can add another point.
No.
No?
No.
It's a
not
white
that.
cataract.
That is the option is
It's
there.
a white cataract.
But
Sorry?
It's a white cataract.
Yeah, but the point is that once the cataract is out at that time, and even at that particular time, I'll
No,
show
the
you a lot
vitreous
of
was
videos
presenting even beforehand.
even beforehand, you make the trocar cannula and do it. What's the
No,
problem?
that is okay.
No,
Anterior segment surgeon.
don't
Once
argue with the
you-
jury,
You
please.
need not, you just do a vitreous decompression of whatever is coming out. And then once you have the visibility, you can go ahead and do it, because you don't get a hydration. So I don't know, that's what.
No,
I
we are not
normally-
taking it away. But
Sorry?
he has still done it well.
I know he has done it well, that's not a problem, but some points, ultimately I may also say not guilty, but there are some points.
I think the end result was good, but 2-3 things are very important for beginners, at least if they are going to follow the surgery. Number one, like you said, pars plana would be a much more safer technique as compared to the anterior vitrectomy from the anterior route. And the Gore-Tex did seem a little loose. So if it is well covered with the scleral, under the scleral pocket, Hoffman's pocket would be a better option. So that would have been much more elegant. Yeah.
I think the only thing I could add also, the Hoffman's pocket, if it
Let's
is made,
also do
it
something.
has...
We
sir?
can also add something.
Ramamurthy
sorry,
has also
sir.
done this.
No, I think overall excellent results and well done. And I don't essentially agree that the ease with which you did the rhexis, I would have done the same thing. It's not that all white cataracts are intumescent and bulging forward. Obviously, there could be a more flocculent cortex, and maybe there was not too much of intralenticular pressure. The fact that the ease with which you did it, maybe that's the right way. But I do agree with Mahipal that I do most of my anterior vitrectomy through the anterior route only, not through the pars plana. But this is one situation where there is a what a lens has moved away, it's subluxated traumatic cataract, anterior vitreous presenting anteriorly. You could have done a pars plana vitrectomy for a more complete vitrectomy. And we could notice a white patch even at the end of your vitrectomy being completed, which shows that there were still vitreous strands. Of course, the challenge would have been that because you had a white cataract, you couldn't have seen the vitrectomy probe inside. So I would have, as he mentioned, maybe at the end of the surgery, you could have just gone in through a pars plana route to make sure that the vitreous has been completely evacuated. The Gore-Tex, yes, you did it well. It could have been buried. But then I feel that you could have even used a 5-0 proline and just cauterized the two edges. And it seems to work out very nicely and very quickly.
Come
where once you go through the CTS ring and cauterize it on one side, it makes a bulbous this thing which holds it, and then bring it back like a flange technique, something like a Canabrava technique.
Dumbbell technique.
And then again flanges, cauterize it outside. And if you had taken it through the sclera, then you can bury it nicely. Nothing is seen outside and it stays.
So the only thing is we know that proline is over a period degradable over probably a decade. And this is a young boy.
5-0 usually doesn't degrade, and we have been.
It is going to eventually. So we thought that 10-0 did not degrade, and we know now that it does. This is a young 20-year-old boy.
We have seen a lot of Gore-Tex granulomas nowadays. So just putting it under the conjunctiva is not a good idea, because we have seen them coming out of the conjunctiva, having lots of pus around it. That's of course a sterile pus, but there is still inflammation going on into the eye. They do have anterior segment cells and flare just because of that Gore-Tex granuloma, and we have had to cut lots of those granulomas in the OT and then getting a better result. The first thing. The second thing, we also saw pupillary iris defect at the end of the surgery. I would say that you could have sutured that iris, given a smaller pupil, so that the aberrations would have come down and patient would have got a better result. This is just to add some elegance to the surgery.
Thank you. I think heard everybody. Basically, take home messages. He has done excellent surgery. There was no any flaw in the surgery. I really appreciate Abhijit. You have done excellent surgery. But take home message is that it will not happen in everybody's hand like this. So whenever we are doing, better to go the scleral pockets, because the conjunctiva, definitely you get the foreign body sensation, sometimes degradation of the conjunctiva,
erosion.
not will poke out. Secondly, about the vitrectomy, always better to go to the pars plana vitrectomy so that properly can be done. Other thing is debulking. Yes, patient is only 20 years old. So putting knot in conjunctiva, debulking, and also the pars plana vitrectomy is important whenever you are thinking for the very young child, because age of the young child will be more than 70 years after this surgery. So we must take care of the pediatric cases. Pediatric cataract is totally different from senile cataract, and accordingly we should treat. But here I think what my jury is saying, jury, guilty, non-guilty?
Have said guilty, sir. 3 jury members have said guilty, sir.
Guilty, non-guilty juries?
He got away with it, but
Okay, partial at least, Sri Ganesh. Please. I need to set the stage for the next.
Basically the partial. No. Say.
Not guilty.
No. He is not guilty. He is not guilty. See, as the both people who are saying in the center is guilty and not guilty, both are cataract surgeon, and because of that, every cataract surgeon is very much fond of other cataract surgeon. So because of that, it might be happening, but he is not at all guilty, and he will be garlanded by the Ramamurthy will garland him. Come, Abhijit.
So the next, boss, music ko halka halka rakhiye. So before we come to the next, this is a very, very important case in the court of law. And again, honesty and judicious judgment is what I request. So relations don't matter, justice matters. I call upon Dr. Soham Basak. বাংলাতে শপথ নিতে হবে।
আচ্ছা, হ্যাঁ, ইয়েস। তো আমি শপথ নিচ্ছি, যাহা বলিব সত্য বলিব, সত্য বই মিথ্যা বলিব না।
Shall we start the proceedings?
Yes, sir. This is play from here.
Achha. You want it to be played?
Yes, sir. Okay. There's like slight change. I've added documentation to this.
This
the
one?
edited video. No, this is not the
Not
one.
this one, not this one, not this one. Not this one. We have just 4. Sachin is there and Shaiban is there.
Yes.
No.
So
This session was to start at 2 o'clock and then goes over to 3 o'clock.
So here's my presentation. It's called DALC All the Way, no financial interest. So the story is, okay. Yeah, the story is of a 62-year-old gentleman, one-eyed with advanced keratoconus and moderate cataract. The other eye has a significant scar, and as you can see from the Scheimpflug and the AIOC, he has got very thin corneas and a Kmax of almost 80. So how to manage? So this is what I decided, DALC followed by cataract surgery after 6 months, since patient will retain own endothelium, and we can do a faster steroid taper. So begin by marking the cornea and a partial trephination. Followed by doing an anterior stromectomy about 50% of the depth. So now attempting a big bubble with a 27 gauge cannula, and this happens. So failed big bubble, air in the anterior chamber. So, and unfortunately I have only DALC tissue. No, so can I finish the manual DALC? Let's see. So very meticulously I switch over to doing a manual DALC technique. This is the groove and dissect technique where only blunt instruments are used. So all blunt dissections using a conjunctival scissors and then making a groove all around. I added some air bubble to aid in sort of visualizing the depth of the dissection. And then sort of dissecting blunt dissection of the remaining corneal stromal lamella. And here you can identify where the perforation site is. So decided to again dissect from the peripheral side very gently and refilling air bubble just to maintain the anterior chamber. And that's mostly the corneal stroma taken out, and it's actually a desmetic DALC. You can see the shiny descemet membrane underneath. Now that the central part has been taken care of, I can remove most of it. So here I got a little bit greedy and ended up with a smaller perforation and decided let's end it there. And I had no other option of doing this because this is the tissue I'm left with. So this is the remnant of a DMEC. So I have no optical backup tissue at all. So went ahead doing a little bit of an edge trimming so that the suturing is more flush. And the rest of the suturing is pretty straightforward with 10-0 monofilament nylon. And I have kept that air bubble at the end of the surgery, checking for leaks. However, on day 3, he comes with this. There is a double anterior chamber and a descemet detachment in the inferior part of the cornea, and required air bubble and repositioning for another couple of days, and hopefully it cleared up. And this is at 4 months follow-up. This is his own endothelium. 1700 is probably a lower count because you have those folds. And after 2 months, I'm planning to do the cataract surgery.
Which is pre-op and which is post-op? I mean, okay.
This is
So shall we begin the trial, sir? So the first question is, why did you do a 2-stage DALC, then cataract, and not PK plus IOL? That's my first question. Because, during the surgeries, you as a very, very novice surgeon, you had so many problems. Meaning, would you really think that in the next attempt, you would like to do this and not what you did?
Objection, Your Honor.
Madam, I have to raise my voice. Please take a seat. Again, why did you not attempt the big bubble technique? You have failed in your first attempt. You perforated, and that's a failure again in the second attempt. And I think this was a human eye.
Finished?
No. After the big bubble failed, why did you not convert to PK? A very safe process and possibly a safe one for a novice surgeon like you. And you could have prevented a double anterior chamber in the post-op period follow-up. But the most important case is in your next cases, how are you going to do your next case? Because a message for all novice surgeons has to be that gulp as much as you can. Don't overshoot your
Objection.
limits.
Why so much drama? I think he has to conclude. We don't stop him, he'll talk for 1 hour. Objection is that
You want to defend?
Dalk is they shows a very capable surgeon who's done it. He had a small perforation which could happen, and so beautifully he injected air to stabilize the anterior chamber, converted to the manual step, and completed the case. A double anterior chamber is nothing which cannot be handled. It need not have happened. It happened.
Dr. Tuhin, come and sit in the front bench.
Whole surgery reflects a confident surgeon. But why should he be called a novice and all that? Just because it's honey law, you think you can get away with it or what? Sue him afterwards. Don't spare him.
Okay.
Dr. Tuhin, you have something to say.
He did absolutely perfectly everything. So what happened that double anterior chamber can happen even without perforation also.
Yes.
So that doesn't make any difference. And second thing that you put this air or just C3 in the second visit?
Only air.
Only air. So that was fine.
Yeah.
Perfect.
Perfectly
So there was no
done.
question.
Perfect.
That yes,
Perfect.
perfect.
Are you
And
sure?
Yes,
We are
sure.
very
But
sure.
second thing that the main idea is that we have to preserve the own endothelium of the patient. So to prevent further rejection or anything in future. These are patients coming from different areas, so they cannot get the scope to visit the doctors frequently.
Yes.
So we have to preserve the endothelium of the bone.
So PK was not the answer at all.
So can I
So
answer?
we can move on and hang the public prosecutor.
Yes, you can answer.
Yeah.
So to answer the questions, so why a two-stage DALC? So this is a one-eyed patient. So I wanted to avoid all the complications of PK, basically a higher rejection rate, and the steroid has to go on for a long time. Again, predisposed more towards glaucoma. So that's why I went ahead with a DALC. And since the cataract was not very advanced, he agreed to go for a cataract maybe 8 to 9 months down the line. So the only thing that I would do differently to answer the last case is I would probably go and do a manual DALC right from the beginning. So because older people, the cornea is more stiffer, and it's actually very difficult to get a big bubble in this case. I was over enthusiastic. I should not have done that big bubble.
So you plead guilty?
No. Why should he plead guilty?
Okay. Mahipal?
I think he did a good job. The only thing is that there was a perforation, and the second time you were a little more adventurous when you were separating it at the inferior
Yes,
part.
I got a little
So
greedy.
maybe a little more care at that time. And I don't know, wouldn't an expansile gas have been better than air? Because you knew that there were two perfs. Because that could possibly reduce the chance of double AC.
So then, because the second perforation happened inferiorly actually,
That's
so
precisely the
I
point. So that's, I think, where your DM with the double AC.
That's
formed
where
at
the DM
inferior
would be,
part.
yes.
So what I'm saying, irrespective wherever it happened, if you had put an expansile gas rather than air.
centrally I would have gone for air, but retrospectively thinking maybe C3F8 little bit. But again, higher chances of having a pupillary block. That fear is there.
I think you agree with what I'm saying.
Yes, sir.
I think he managed very well since it was a 1/8 patient. Definitely you want to avoid PK. Perforations can happen. I mean, it's not that these are things that are known problems when you are doing talc. I think he managed it very well. He was able to manually dissect and then get a good result without any complications.
Without any complications, he had a complication of perforation.
Yeah, that is during the procedure you can have small issues which you can overcome, and he overcame that quite well. It didn't lead to a problem which he could not manage or which led to some visual loss or inability to recover for the patient.
I think, see, as it is a patient was one-eyed, he planned properly, and for anybody's hand, surgical complication is not in our hand. So our planning was better. In between there was some surgical complication. How to manage? As one-eyed patient, he has not thought of the penetrating keratoplasty, and whatever work he has done is manually. I think good work he has done, and he is an excellent surgeon. Carried out
I think
good surgeon.
just a couple of comments in the sense that more for our understanding. If you desect with cataract surgery, you definitely go for a combined surgery because the subsequent cataract surgery would be deleterious to the endothelium of the graft that you are putting in. But when you are planning a DALC with a cataract surgery, I think what you did, splitting it up into 2 stages would be the right way to go. That's the right thing you did, and obviously very well done. You kept saying during your presentation that you did not have a spare tissue available.
Yes.
But why do you need a spare tissue? I mean, there was no problem with the, ideally in a big center like yours, spare tissue should always be available because you are a high volume center.
There are days when...
Even, I don't think a spare tissue was there was never a problem with the donor cornea. How will a spare tissue be would have spotted?
No, in case there was if it had been a bigger perforation, I would have no choice but to convert to PK. So, but in that particular day, that was really not an option.
And one last thing more for my learning, I felt you were not peeled off the endothelium in the donor corneal button.
It was peeled off, sir. That's the thing. It was a tissue which already has been used for DMET, so the endothelium is already off.
Right. Okay.
Thank you, sir.
Thank you. Jury, is he guilty? Okay. So, I think
partially guilty.
No, he is not.
For once, he is so happy that he is not being hanged.
He is not guilty. So, Mahipal will garland you.
కోకా కడితే కొరకొరమంటూ చూస్తారు పొట్టి పొట్టి గౌనే వేస్తే పట్టి పట్టి చూస్తారు కోకా కాదు గౌను కాదు కట్టులోన ఏముంది మీ కళ్ళల్లోనే అంతా ఉంది మీ మగ బుద్ధి వంకర బుద్ధి ఊ అంటవా అమ్మవా ఊ అంటవా అమ్మవా ఊ అంటవా అమ్మవా
Dr. Shaiban.
తెల్లగుంటే ఒకడు తల్ల కిందులవుతాడు నల్లగుంటే ఒకడు అల్లారల్లరి చేస్తాడు తెలుపు నలుపు కాదు మీకు రంగుతో పని ఏముంది సందు దొరికిందంటే చాలు మీ మగ బుద్ధి వంకర బుద్ధి ఊ అంటవా అమ్మవా ఊ అంటవా అమ్మవా.
So, you would be playing from there, Dr. Shaiban?
Yes, sir.
Okay. So, your oath, please, madam.
मैं जो भी कहूँगी सच के सिवा कुछ नहीं कहूँगी.
Punjabi, yes.
Okay. मैं जो भी कवांगी सच के सिवा कुछ नहीं कवांगी.
Right.
Go ahead.
Okay. Thank you so much, sir, for the opportunity. So I'll start with my case. So one fateful day, this is what I see in my OPD. This is a completely white eye, giving a history of 1 week old painful loss of vision. The B scan was normal. The intraocular pressure was 40 millimeters of mercury, and we took the patient up for surgery after mannitol administration. A small paracentesis was made to clear off the milky fluid, and we realized that this was a phacolytic glaucoma. But what lied underneath was a big fat lens and a very shallow anterior chamber. So here I was dealing with a phacolytic glaucoma and a very dense nucleus, which poses a lot of problems other than that, like shallow AC, small pupil, iris prolapse. There is a poor endothelial cell count as well. So I had to be very careful. And right from the beginning, there was iris prolapse due to positive pressure and the atonic pupil. So I wanted to do a small CCC because these capsules, which are phacolytic, have a tendency to run out. So I was able to achieve that with great difficulty, although the chamber was shallow, instrumentation was difficult. And so with some courage, I thought I'll debulk the central nucleus. That will tend to deepen the chamber a little bit. So I went in, I made a deep trench on both sides. That was done successfully, making sure at all points that the zonules could be weak, so all the maneuvers had to be very gentle. The trench was completed on both sides, but then at this point I realized that the corneal edema heightened. The visibility was becoming bad to worse. The highly vascular iris also started bleeding because of instrumentations going in and out. And at this point, I had zero visibility. I wanted to sort of at least crack the posterior plate to make the following steps a little easier, but it wasn't possible to do anything at this point. So I was panicking, I was sweating, but anyway, I paused, I re-strategized. The first thing I did was loosen the speculum, and the patient was started on IV mannitol on the table. While I was waiting for the mannitol effect to kick in, I also cleared a little bit of the epithelial bullae by doing a very limited superficial keratectomy with the cotton bud and blunt instruments. And I think it was the effect of this as well as the effect of the IV mannitol kicking in that the visibility improved significantly in a while, and the inner details were more visible at this point. The eye was also softer. So I gathered courage, I took in my probe, and I attempted to complete the case. So there were a lot of problems that I was still facing with. The iris was still prolapsing. But thankfully, I was able to crack the nucleus. I made multiple pieces of the thick, hard cataract. And all of this is done while making sure that the zonules are not being stressed, making sure that I'm well away from the posterior capsule. The capsules can also be thin and friable in these cases. And at all point, one is also ensuring that the endothelium is protected with frequent insertions of viscoelastics. So this is how I was able to complete the nucleus emulsification. The last bit was done at the iris plane, and I was relieved to know that the single piece hydrophobic lens also could be placed in the bag. The eye was soft, well formed. There was no iris prolapse. The wound was opposed, and the eye was closed. The patient is doing really well. Thank you.
So shall we begin the trial now?
Yes.
So it's a tough case, ma'am. Do you feel it's a tough case? Yes or no?
Absolutely.
Yeah, go on agreeing with me now, ma'am. So, bad management of phacolytic glaucoma, yes or no?
No.
Yes or no?
No,
You
sir.
just-
Okay, I'll prove you wrong.
I showed you the end result.
You just keep quiet now. You've done a good job.
Okay.
Ma'am, please take a seat. Now, you have to answer this question. First, foremost, from top to bottom and first to last.
Don't
Why
answer it.
were iris retractors not used in this case?
You don't have to answer that.
Sir,
It was a small pupil. It was a difficult case, intraocular pressure going up, and iris already traumatized because of a high intraocular pressure with atonicity. This iris has to shrink, number one. It has to pop out. It has to make a case which is so difficult, even more difficult. So the iris out of the way, 100% has to be the right thing, number one. Number two, your rhexis, which you did quite centrally, was small, which means the nucleus management, you made it even more difficult for yourself. Again, intra-op mannitol. It must have been a very difficult case where you would have to wait, where you would have to give time. So in such cases, a proper rhexis, a large rhexis maybe, a fast nucleus management, closing the case fast is something that is required. So this is the only thing that I think is important. And madam, I find you guilty, guilty, guilty. Would you like to answer?
No, I can answer for her. Objection, Your Honor. See, basically, yes, iris retractors.
Please answer my questions.
I'm looking at your questions.
And answer them.
Yes, she has used mannitol. She has scraped the cornea. She has completed a surgery. Iris prolapse did happen because
bleeding did happen.
It is an inflamed eye.
Injury did happen.
What injury?
To the iris, nothing.
No.
What do you mean nothing?
No, nothing happened.
Nothing happened. The iris was not injured iatrogenically by the surgeon. Yes or no?
Iris was floppy because of the rays.
Was it injured or not?
No.
It was not injured. So it went just like that.
Both the lawyers, you should address the. Listen. First listen. First listen. Both the lawyers, you should address to the judge and not in between. You should not talk each other at all. You address to the judge.
No.
Okay.
He's become impossible to handle.
No, you can fight outside, but here you must address us.
Okay.
Okay,
So
yes.
I
decorum should be maintained.
Yes, that iris retractor could have been used. The
Good, should and
you
must.
Are not.
Again, you're doing should and must.
So I would like us to understand there's no need to keep going back to it. We all of us know. But she has had a good outcome. She was capable of doing it. There are many surgeons who don't use iris retractors. I use iris retractors drop of the hat. That does not mean anything. It is just her individual approach, and she has reposed her iris. For that matter, I wouldn't reposit the iris from the main wound. I go to the side wound and reposit the iris. But she has completed the surgery well. That's the end result. You need to hang yourself for misbehavior in the court.
Can I add something to defend the public prosecutor actually? So the thing is, first of all, while seeing the video, we realized that after starting the mannitol, things came into place. So first of all, she should have started the mannitol before she gave, but she should have started it along with the surgery so that the dose was inadequate. The
I think in the next session we'll call you over here.
The second thing, can I go ahead? Yeah. Second thing that the conventional teaching says that before taking the cases to the OT, you should measure the pressure digitally so that it is less than 10 before opening the eye, so that all this positive pressure and all this stuff goes down. And I think that's it.
Thank you. See, of course, mannitol was given, which is important, but then I would have definitely used a pupil expander because the pupil was small to start with, atonic, and there's a lot of inflammation and it can come down during the surgery. So if you don't have proper exposure, doing a good rhexis is again an issue. And then if you have an atonic pupil, you definitely have iris prolapse, which happened, and then you can have iris shaffing and cosmetically a bad result. So that definitely use of pupil expander would have made it easier. Giving mannitol on the table is something that I do not favor, especially in a prolonged case, because what happens is then the patient becomes uncomfortable because they need to go to the toilet. And what could have been done if the pressure was high and it was difficult with a lot of iris prolapse? You can do a limited pars plana vitrectomy where you just aspirate a little bit of vitreous so the eye becomes softer and then it's more easy to manage. Removing the epithelium, of course, if the epithelium is edematous because there's a long-standing high IOP, that's a good technique to improve visualization. But definitely a limited pars plana vitrectomy also can help. But definitely using of the iris retractors or a pupil expander would have helped. And the other thing is, most of these cases, the cortex is liquefied, the phacolytic glaucomas, and typically you have a very mobile nucleus. And she was sculpting. So sculpting techniques are not ideal. I would prefer to do a direct chop, which on a mobile nucleus sculpting, again, you can kind of push against the zonules, weaken the zonules. So again, a direct chop would probably, so these are my inputs. But overall, she was able to manage and get away with it. Visual recovery would have been probably good, but again, cosmetically, because of the iris chafing and depigmentation and
post-op recovery also would be a little stormy.
Yeah.
So much of iris handling.
Shiri, you have been pretty kind to her. She tried everything not to get a good recovery. I think, first of all, right from the beginning, it should be a vitreous decompression. You should be prepared for that. Second, I didn't hear her say that she used something like phenocaine. That should have been immediately used, and possibly the pupil could have been dilated. The third was to have pupil expander. The fourth was, I think the tunnel was slightly short. That's why you were getting the repeated this thing and going through the same place again and again, causing injury to, I'm sorry, I don't want to use a harsh word, but it was not the done. You could have sutured up that incision and moved to another better incision so that you are not getting the injury to the iris, because the iris was getting injured again and again. So these are a couple of the things. Vitreous decompression at any stage would have definitely helped to bring down the pressure. And mannitol, what was rightly said is at that particular time, you should, before taking up the patient, you should try to see that adequately that the pressure is controlled. That is something that is required. So you got away, you were lucky. And the other thing what he said was, I think your technique to chop was not excellent. It was just neither here nor there. You were very superficial in holding the nucleus. If you go back, look at your video, you never trenched, you never, even if you were doing a trench, you never went deep enough. You were pretty superficial, so you never got a hold of the nucleus to be able to crack.
The clarity was not there.
Sorry?
The clarity was not there.
No. Chitra, when you started, the clarity was that she didn't bury deep enough. And a direct chop would have helped, and she could have had, right at the end also, you saw that the posterior plate was still there when she aspirated. It hadn't cracked in the middle, so she should have ensured that it should have cracked. So overall, I think you will learn over time, but there is a lot of improvement which I feel could have been done in this case.
Very difficult case.
Yeah, I think it was a difficult case,
Yes.
and the end result was good. There are 2-3 things which one I think has to remember, that it was a phacolytic glaucoma. So probably earlier it was not dilated. The patient was not dilated before starting. The mannitol was given, as I think Dr. Saiba said, and phenocaine was put in once the liquefied material was cortex was I think taken. What did you put the phenocaine?
Yeah.
That's,
So those
that's how it
steps
was
wherein
a little
the
dilated.
lignocaine and the adrenaline, the trypan blue and the visco was placed have been skipped because of shortage of time. I directly showed from where the rexus was started. So now the iris also started prolapsing. See, now the idea why I did not plan a PPV was the fact that there was no visualization. I wasn't sure this was a phacomorphic glaucoma along with the phacolytic glaucoma. Normally what happens is when you have a phacolitic glaucoma, you have a small nucleus and you don't have a shallow anterior chamber. But this was a combination of both, which is very unlikely. The reason why I wanted to show this case. But when I entered and found that this was a fat nucleus, at that point, I think the first conservative approach would be to try IV mannitol when things settle down. At that point, I don't think I did not feel the need to do further interventions to deepen the anterior chamber because surgery was going just fine.
I think the surgery, what you did is very good. But basically, this is not the case to be presented in the court martial at all. You should not present, because see, you may be a good surgeon.
So the
But when listen, the basically when the people are sitting here and they are going to criticize on the case. In such situation, you should not present. This is an excellent case for OPL and not for the court martial. So I think whatever she has done is next time she should present this case in OPL. Here now it is very difficult to save her, and all these people they are not going to be good for her. So without asking anybody, I say she is not. She is going to say something.
I think no, it's a nice case for discussion, and I really feel it was a phacolytic glaucoma, not a phacomorphic glaucoma. So there's absolutely no problem in dilating the pupil preoperatively. And secondly, you already said that preoperative mannitol had been given. So repeating the mannitol again must have been an elderly patient to end up with this on the table is definitely asking for trouble.
Surgery
And
was actually
like Dr.
done.
Sri Ganesh and both Maipal said, this is a classical case where vitreous decompression should have been done. When you're having such kind of a upthrust and shallow anterior chamber, you also said that the endothelial cell count is very low. Just not even an anterior vitrectomy, just putting in a trocar would have allowed the fluid to flow out, and immediately the whole thing would have settled down nicely, and much of the prolapse of the iris would have come under control. And again, the way you handled the iris when it was prolapsing, you said it was a vascular iris. There is no reason for the iris to be vascular. It was just that there must have been iridodialysis which bled because of the reposition. So going through the side port and repositing it, putting a blob of cohesive viscoelastic or viscoat to hold settle the iris down would have been the right way to proceed. And most of your phacoemulsing, as was said by both of them again, the nucleus neither was it chopped nor was it fragmented, and you already said that the endothelial cell count was low. And doing this in the anterior chamber would have been quite deleterious. Obviously, a very challenging case. Maybe any one of us would have had problems in doing this case, but there are certain learning points in this, and it could have been better handled in some aspects.
Plea bargain.
Please let her leave her alone.
This is
Not
the
guilty.
court of law. I have to tell our jury and the supreme judge, this is a court of science and a court of law. So let us be judicious.
What are you asking?
Don't photograph this. Don't photograph this.
Let us.
Guilty?
Yes. The defense counsel is guilty of taking up this case.
I think the opinion of all jury and supreme judges is same. See, the take-home message. She has done good thing, and she will not be hanged. But basic thing is
she will be asked to present an OPM.
But see, always remember, whenever you are doing any case, here you must know the science. The science is very important, and everything without science, if you are managing the case, in that case you are going to be in the trouble. And such cases when people is not dilated, nothing, there was no any you can say neovascularization of iris, it was just an iris, you can say the dialysis there. So like Mahipal said, ki second site you go, then pars pro vitrectomy, all pupil expanders, very important. Just doing you can say, I don't want to use the word butchery, but don't do like that. Ki whenever you are operating, you should be very careful. And I always say that you don't be an offensive surgeon, be a defensive surgeon, because that is very good for the patient. But yes, she has courage to present case here, and she has done an excellent case. So managed it good. So she is not guilty, and I will myself garland her. No problem.
The defense counsel
A
accepting
very
this case.
reasonable judge. Others have to be dealt with.
Come on,
So now, Dr. Sachin Mahuli. एक और. So in Marathi, your oath, please, Sachin.
Kannada, sir. I speak Kannada.
Kannada?
Yeah.
Okay.
ನಾನು ಹೇಳೋದೆಲ್ಲ ನಿಜ, ನಾನು ಹೇಳೋದೇನು ಸುಳ್ಳು ಹೇಳ್ತಾ ಇಲ್ಲ.
Okay. Shall I play?
Yes, sir. Okay. So this case had a small story. This case was operated by one of my colleagues.
VR surgeons come to the forefront.
Very bad diabetic vitrectomy. He had an intraoperative bleeding and he had to abandon the case in between because of the massive bleeding with the silicone oil in place. So he referred it to me so that I could manage it further. I decided to do it under oil infusion. Generally, we do it under saline infusion. We could have removed the oil and then put do a vitrectomy again and then do the membrane dissection and then probably re-induce the silicone oil. But I decided to do the surgery under the silicone oil infusion. So there was a constant infusion going on with the assistant with the silicone oil, and I was really amazed the way we could maintain the clarity of the chamber during the surgery, because if it starts bleeding in the saline, the visibility would have been very difficult and I would have ended up in the same situation as my colleague would have ended up. So the vitreous was behaving very well under the silicone oil infusion. The cutter was behaving well. I could dissect most of the membranes. I could dissect most of the vitreous from the retinal surface. We could get a good cleavage. Most of the membranes were also dissected very well with the cutters itself. Actually, the silicone oil aided as a second hand to me, wherein when I was peeling the membranes and see if you can see the vitreous being pulled by the cutter to find the plane, the oil seeped inside and it was making the retina fall back. So once we could get a good plane of the vitreous, the vitreous just behaved like as if it was in saline. The only drawback in this was the constant pressure of the eye had to be maintained because the assistant was injecting the oil constantly and I had to keep checking the optic disc pressure all the time. This is the only drawback. Otherwise, it did aid as a beautiful second hand. The oil behaved well. The media was cleared throughout the surgery and we could dissect almost all the membranes and give a very good anatomical as well as visual recovery to the patient. See, even the last bit of vitreous which is remaining there, we could trim it beyond the arcade and we could trim most of the vitreous quite well. Laser was done to the existing brakes and to the iatrogenic brakes. You can see the retina is already flat. So this case would have been more difficult if I had removed the oil and done it under the saline, because it would have got totally hazy and I would have to wait till the bleeding stops, and it would have been more complicated. The surgery was finished very fast. Subretinal fluid was removed. Whatever subretinal fluid was there, it was removed, and the brakes were lasered completely. This patient did very well post-operatively. He had 6/18 vision. There's a laser being done to the brakes.
6/18. Huh? Must be the other.
Don't drag this. What are they doing?
Okay, I think that's the end of the case.
Your defense counsel wants to go. Will you release her, please?
नहीं,
You may go.
Madam,
इस केस को तारीख दे देते हैं.
अरे एक वो डायलॉग था सनी देओल का, तारीख पे तारीख. यहाँ सब कह रहे हैं अगली तारीख पे सुनेंगे.
नहीं सर, इसको नहीं छोड़ेंगे.
इसको क्यों छोड़ना है?
Look at that. it's going to start.
नेक्स्ट इसमें जब उनका केस अच्छा हो जाएगा,
नहीं,
we'll
इन
see
लोग
the
को
good
ना
follow-up.
रेटिना कुछ भी नहीं मालूम है, हाँ? ये कुछ भी
Madam, you sit,
बकेगा, and
you
then
sit,
when I try to
you
convince,
sit, you
he will
sit,
call some
you
retina
sit
guy.
and read up all this.
Yeah.
Now, this is a very important thing.
Even I-
Dr. Sachin Mauli, the actual basics of vitreoretina surgery is absolutely slashed in this case of yours. I don't know for what reason were you trying to do make yourself things difficult for yourself, or were you trying to cost save? But a huge amount of retinal damage is what would have happened in such a case.
Don't worry, I'll take
Silicone
care of
oil makes the cutter more difficult to cut, and the membrane cutting is definitely much more difficult. You have to agree to it. And multiple attempts have to be done to hold the membrane, the tissue, etc. And with the cutter working in the oil, you said that it would have become cloudy. I don't think so. You definitely should have done it in
Objection,
fluid.
Your Honor.
No,
He's saying all wrong things.
Please sit down. No, these are very
what
important
you're saying
things.
is wrong.
We have vitreoretina surgeons here.
Yes.
They have to
Yes.
say yes or no to this.
Yes.
And multiple times you have to hold these membranes, and it becomes very difficult, especially if there is no counter traction to it. Now, a complete membrane removal is also very difficult. And if you leave behind membrane islands, then PVR is definitely there to set in. So these aspects are important as basics of VR surgery. Cutting and attachment of the membrane, again, and the laser is a further damage and to the retina, and again, PVR changes are bound to occur.
Okay, you have said enough.
The SRF removal, please. These are important points. He has to answer them. He is a vitreoretina surgeon, not an. Pura jayega, sir.
Oh, time nahi hai.
Now, the next thing is, now every time it is under oil and you're aspirating, you're going to aspirate oil, and that itself creates hypertony. These are absolutely basic things that we have learned. Now, you have to increase the laser power here, and that is even more damage to the retina and retina necrosis. Madam.
Okay, now.
You take a photograph of what?
No, let me
and you can
answer.
go to the apple tree.
No.
And last but not the least,
No.
very important, you've put an infusion cannula in the temporal quadrant. Again, the basic rule of VR surgery. Okay. So these are important
Public
things.
prosecutor, who wrote all these points for you?
No,
My VR surgeon wrote it. My VR surgeon wrote it, and that's the science of it, sir.
Okay, finish. You're finished? No, now I'll tell.
Take a photograph
Objection,
of all
Your
this
Honor. Okay,
and give a reply in writing.
No. Objection, Your Honor. Under silicone oil doing surgery allows you to do a neat vitrectomy, a good dissection. After that, and it also acts as a tamponade for bleeding. Okay, so you listen to this. After that, the silicone oil needs to be removed so that the endo laser could be done, because with the silicone oil in the thing, to do laser may not be good for the probe. That's all.
Oh,
Nothing
good
will
for the
happen.
probe. Good for the
Nothing.
retina.
All this
With
nonsense which is written does not happen. And after that, he should do a silicone oil exchange. Should have been done. Has been done.
No. Laser can be done under the oil.
Yes.
We do most of the surgeries, recurrences under the oil now.
Yes, exactly.
We are doing.
Can we take a
So
VR
he
opinion?
does not know that.
Yeah,
How do
my
we teach
VR
him
colleagues,
now,
VR colleagues would understand what I'm saying.
Yeah.
Because none of this.
For the re-surgery, it can be done.
Let some.
Yeah.
No, scientific. Oh, only
Please,
it's
sir,
very
talk.
important to be scientific.
There is
Madam, please sit down.
Please don't stand between lunch and us.
There is a case series by Dr. Steve Charles, who is the founder and pioneer in the cases of VR surgery. He has proven in his paper that seeing the membranes under oil is better. And peeling oil provides counter traction, and you can relatively easily peel the membranes, if at all it is possible. And later on, you can just top
is
up
that
with silicone
only
oil.
one study that says it? Normal basics.
We have our own case series. We have named it as minimally invasive PVR surgery.
Yeah.
And we introduce only 2 cannulas. With the help of it, we remove the membrane. We just top up silicone oil.
No, in
The
short,
results are excellent.
in short, neither the public prosecutor nor the defense counsel nor any of us understood what was going
No,
on.
no, 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 no. You didn't
So the-
understand.
no,
I
no.
understood. No.
Scientifically, you come over, boss.
It is not guilty.
Boss, you come over.
Okay.
No, science, speak
Actually,
science.
the eye is in ICU, and in ICU the eye has got a heart attack. So everything is fair in love and war. So this was war. So everything what he did was perfectly.
Now
okay
let's
as a
go to
real
science.
surgeon.
Retina, you have to speak what is scientific.
Wonderful. The important
public
point, I think,
prosecutor.
approach for doing the whole procedure under oil. It was a very, we could see a lot of bleeding on the membranes. We could see thick amount of clots actually remaining there. And it was actually maintained by the oil. The moment you, as he said, you're going to put the infusion, you're going to create that bleeding to come up much more. And then it's even with PFCL, then you're going to have a huge challenge. So I think approaching this through oil initially was certainly the best thing to do. The other advantage you get with oil is the traction on the membranes is much lesser. Your vitrectomy time is going to be much more, but the traction on the membranes is much lesser.
Thank
Great,
you.
kudos, fantastic.
Thank you. I think
Not
he
guilty.
is
The
not
court
guilty,
is the court is adjourned.
and court is adjourned. As the points are very much, we will study next time. Thank you.
Good, oi, bud. Allah, mat wala barfi. Pao bada mota chala barfi. Rato ka hai ye ujala barfi. Gumsum hi machaye ye to utpaat. Kur rafat kare non stop. Kur.